For those of you that may or may not know me, I'm Steve Spinner. I run the Medicare Advantage here for New Horizons Marketing. As an integrity partner, over the last 3 or 4 years, it has been an extreme pleasure to come to know some of our bigger brothers and sisters and the asset that we can all be to each other. And one of the largest and the best reasons to even to be thinking about integrity is the immense amount of synergy that we can bring to the table for any independent broker out there. It's been my pleasure to come to know a lot of people, but my closest confidant to any of my brethren out there is Chalen Jackson, who has been an immense source of knowledge, advice, and I'm going to stop talking here a little bit because Chalen's advice, he's got a lot of good points to come to. So with less ado here, I'm going to introduce Mr. Chalen Jackson as our compliance guru. Chalen, take it away.
Steve, thanks so much. I always appreciate the chance to get in front of any of our partners and really enjoy working with all of you, and especially the folks there at New Horizons. What an amazing crew. And you're right, this is going to be kind of a crazy year with a lot of changes. And I've got a quick slide deck that I will start pulling up for folks to look at. Going to talk a little bit about kind of chaos, confusion, and opportunity this year, but just a couple quick housekeeping things as we go through this presentation. I'm sure, and I truly hope that you have a lot of questions. If you do, please pop those in the question box. I probably won't get to them until the end, just because I want to keep us in time, but pop those questions in as soon as you think of them. And if we don't answer them in the presentation, I'll be sure to backtrack and go through them at the end. And here, as long as you all need me, I think we've got this booked for an hour, but if we need to run over a little bit, I'm happy to. Don't feel like you need to leave on my account. But with that, I want to talk a little bit about why this AEP is going to be different. And you've probably heard that from a lot of people, whether you simply watch the news or whether you've been following the content coming out from any of the integrity partners about why this AEP is, like I said on that first slide, chaos, confusion, and opportunity. And there's a lot of reasons why. So we're going to go through some of these things that are making this AEP so crazy and why we anticipate such a large amount of change. Everything from the MA rate notice and some changes with other types of insurance, lead generation, and then of course kind of the two big things that we'll dive a little bit into the nitty gritty on are the Inflation Reduction Act and the final rule. So without further ado, the bottom line on this one is we anticipate this year, this is from our friends at Deft Research, another integrity partner that has the most sterling reputation of any research firm I'm aware of. They anticipate 45 to 70% of beneficiaries in an MA plan this year may need to make a change for 2025. What I want all of you there on the call to understand is that is 3 to 5 times more than a normal year. 2023 to 2024 is around 18%, and that was already an abnormally large shopping year. 18% of folks made a plan change 2024 AEP, 3 to 5 times more than a normal year coming up this AEP. So you need to figure out a way to see 3 to 5 times as many people as you normally would. Let's talk about why. Why is all this craziness happening? Why are so many people going to need to make a change? Way back in February, we started seeing things like the MA rate notice. This comes out every year. It's some updates to CMS payment policies, everything from how they weight certain star ratings elements to how the physician fee schedule and other reimbursement amounts change. And at the end of the day, it's not so much a here's how much more we're going to pay a Medicare Advantage plan or how much less we're going to pay a Medicare Advantage plan. It is more of a conglomeration based on everything that CMS has done over the past year and expecting to do this year. Here's what we think the average change in top line revenue for a Medicare Advantage plan is going to be. In 2025, that is expected to be an increase of 3.45%. But in general, carriers kind of viewed this as a cut, as a decrease in their compensation. A lot of reasons for that: rising costs, rising medical inflation, performance pressures, the changes to star ratings make it harder for them to hit some of those performance bonuses, as well as just some changes to plan administration and some additional costs that we'll talk about later that the carriers are having to bear the burden of. And again, pop questions in at any time. Even if we don't get to them till the end, we will answer as many as we can. Another big thing, short-term limited duration insurance or short-term health plans. There is a rollback of some Trump era regulations that extended those out to 3 years with a 1-year extension. Those are being rolled back to 3 months with a 1-month extension. Carriers cannot sell someone a short-term plan more than once in a 12-month time slot. So this is a drastic reduction of the availability of those short-term health plans. It's not going to affect a lot of your Medicare beneficiaries directly, but it is going to affect how you handle some of your households, because it's going to affect retirement decisions. Maybe someone chooses to work a little bit longer so they don't have that gap where they need a short-term plan. Maybe they've got that lagging spouse that's a little bit younger and they don't want to pay the ACA premiums or pay for COBRA or whatever the case may be. It's going to change maybe some more ACA business for you if you write ACA and Medicare. Obviously, we've got a little bit of overlap in those. And then just in general, going to cause a little bit of challenge for agents who do write these type of policies. Now, here's the deal. This big change happens 9/1. Anyone who has a plan on the books prior to 9/1 is grandfathered into this 3-year time scale. And I know there's a lot of carriers out there that we work with, that all Integrity Partners work with, that are having some pretty creative ideas on how to help you stretch those folks out for another 3 years. So if you're in the short-term market or have clients that would benefit from that, for sure, reach out to the team at New Horizons. We've got some great solutions to make sure that you still are able to help those clients. Med Sups. Obviously, AEP is one of the top times for Medicare supplements to be written. I know a lot of agents are surprised by that every year, but at the end of the day, it just is what it is. We're already seeing clients. We're already talking to all of our drug plan clients. It's a great time to shop that Med Sup as well. And as we go into this AEP, I'm sure it's no surprise to anyone who pays attention to anything. We're seeing a lot higher rate increases than we're used to. Pretty drastic ramp up in some cases, where double digits are now the norm. So because of that, we've seen a lot of questions about, are Med Sups dying off? Are they changing? Are they going away? They're not at all going away. Medicare supplements are still a top tier solution for the right client. It just means the people who are the right client may be changing a little bit. Olivia Richardson in our office is really fond of saying Med Sup and PDP combo may become a little more of a luxury good type product, something for your higher net worth individuals, as we see these rate increases continue to move into that double digit mark as the norm rather than a fluke. Lots of reasons behind this. Loss ratios are up, and they're up for reasons that may surprise you. It's actually that age-in population, that 65 to 69, that is driving up those claims. This is the COVID catch-up that we've been hearing about for the past several years. The folks that didn't get their hips replaced, didn't get their knees replaced, didn't get their cancer screenings, didn't get all of those kind of chronic things taken care of. So now they're much more serious, and there's just a lot more of them happening at once. Those age-ins, those younger generation is what's driving a lot of these claims. And of course, price stagnation means that if you look at a Plan G Med Sup from, say, 2014 and look at one today in 2024, you would be shocked to see how close those premiums actually are. As carriers open up new blocks of business, carriers come in and out of the market, we have seen stagnation, very little difference between what a T65 paid 10 years ago and what they pay today. No other part of our life has seen the kind of price stagnation that Medicare supplements have. So by and large, people are still drastically underpaying for that coverage, especially in those younger age brackets. A couple folks are asking about, are they going to get the slides after this presentation? You're welcome to the slides. I'll leave that up to Steve and them if they want to distribute those. As you can see, it's really Cliff Notes is all it is, but you're welcome to them. New GI rules, definitely a lot of buzz and talk about birthday rules, anniversary rules. I'm sitting in Columbia, Missouri today. We've had a MedSup anniversary rule for as long as I can remember. So we're kind of used to it. But I know Illinois, a lot of other states are pretty new to the whole birthday rule discussion where folks have that GI ability to change MedSups on an annual basis. And what do we see that doing? Lowering commissions. A lot of folks aren't liking to pay on that birthday and anniversary business, and lower number of choices in the market. If you look at states that have had a long history of these extra GI windows, Missouri, Washington, California, New York, compared to a state that does not have that option, we see fewer plan choices, fewer carriers in the market, and we see higher premiums. So as more states have added those new rules, those new GI opportunities, we're starting to see a little bit of catch up as those rates continue to go up. So this is something that we can expect to continue for the next few years at least as things kind of get caught up. But again, this does not mean the MedSups are going away, does not mean that they're not still a super valid and viable option for a lot of your clients. It just means how you talk about them may be a little different. It means which plans you offer may be a little different. If you haven't been on one of the integrity webinars talking about Plan N and why to offer Plan N, really recommend that you hop on one of those. It is a great MedSup option for folks who value that portability and that ability to see any doctor they want, but they're also a little more cost conscious. So hop on that webinar for the full discussion of why Plan N, any of the pitfalls, how to discuss those. But again, just look at MedSup in a little different light as we go into this AEP and beyond, and be prepared to answer more questions than usual. Lead generation. There's some challenges going on. If you've been following things, you might have noticed that this is an election year. We've got a presidential election. We've got a number of gubernatorial elections on top of Senate and Congress and state and local elections. It is a huge election year, and that always plays havoc with lead generation. The mail slows down. Cost per click on digital gets more expensive. It's harder to actually buy local media if you do TV, billboards, radio, anything like that. Even the carriers will tell you in an election year, they get priced out of the market on things like TV and radio, even newspapers. So if you use any major media, buy those spots today. Once August rolls around and the candidates are locked in, we have all the primaries, all the state conventions and thing, and we're locked into who's going to be on the ballot in November. That's when marketing is going to get hard to purchase and when it's going to get expensive to purchase. But in some cases, just hard, just nothing available. Lock in that marketing budget, lock in those choices of where you want to spread the message. Even if you don't know what the ad copy is yet, write the check today. Make sure that you're locked into that. And then pay attention to one-to-one consent. This was a footnote in the final rule that we're going to talk about later, but the bigger news was out of the Federal Communications Commission back in December when they pushed forward this along with a bunch of other provisions on lead generation across all industries. Here's the basics. The idea is if an individual person, a consumer, is filling out a lead form, whether they're calling a phone number, filling out a postcard, clicking on a link, whatever the case, they deserve to know three things. One, they deserve to know what they're calling about. The ad that they're seeing has to be topically related to what the person on the other end is actually selling. No signing up for a cruise and actually getting sold new tires. No thinking that you're applying to be on Jeopardy and actually getting sold a MedSup. Has to be topically related, has to be clear what the product or service being sold is. They deserve that when they click that link, call that phone number, fill out that form, that it is going to one person at a time and that they know who that person is. So one-to-one consent means if you're generating leads, no matter how you're generating them, that individual needs to know what's being sold, who the person selling it is, and that it's one at a time. So no more shared leads, no more aged leads, things like that. Your name's going to have to be on every lead generation source that you want. It's going to be a lot more difficult to get shared leads. You're going to have to do a lot more research on your lead vendors and make sure you know what processes they have in place to help with this one-to-one consent. And the big thing, especially if you're doing digital leads, phone leads, live transfers, anything like that, make sure that you're collecting that proof of permission to contact and all that consent information before you ever make the first phone call. You're required to have that in place before the first phone call is made. So make sure you're paying attention to that. More on that later. If y'all have questions, keep popping those in and I'll address them as soon as we can. Now, Inflation Reduction Act. This is getting into some of the nitty gritty stuff. This may take a little bit longer, and I'm sure you all have lots of questions. And this is a big, big deal. The Inflation Reduction Act happened way back in 2022. There have been a lot of things going forward with that over the past few years. We saw everything from $35 insulin, $0 vaccines. We saw this price negotiation start a couple years ago. We saw the end of the co-payment in the catastrophic coverage phase hop in this year. And now we're seeing kind of the final iteration of the total Part D redesign. So the Part D program is not the Part D program that you are used to anymore. I've had a lot of agents try to draw a lot of parallels, try to draw a line from this year to next year. Where does this go? How does that fit in? And you just can't do that because the program just looks different this year. $2,000 troop, $2,000 max out of pocket, whatever's the easiest way for you to understand it. Just that when the client and certain other payments have hit $2,000, they don't pay another dime for formulary covered drugs at in-network pharmacies for the rest of the year. Elimination of the donut hole. There are now only 3 coverage phases. Deductible phase, $590 is the maximum deductible on a Part D plan this year. Initial coverage phase, your normal copays, your coinsurances, and then catastrophic coverage phase. Once they hit that $2,000 true out of pocket, they pay nothing after that. Big thing to think about here is the cost shift is moving most significantly to insurance carriers. 4 main buckets of money when it comes to a Part D plan: client premiums and copays, Medicare reimbursement and reinsurance, drug manufacturer reimbursements and rebates, and then CMS's chunk that they pay, the carrier's chunk that they pay as well. The biggest increase going 2024 to 2025 is on the carrier side. The average carrier right now today is spending 11% of the total cost of insuring a beneficiary. That's what the carrier chunk is. Starting next year, that's going to go up to 29%. That is a huge cost shift to our Part D carriers. Something a little bit further down the road, starting 2026, is that price negotiation. CMS is already involved in those negotiations, and we're expecting to see that first round of maximum fair values for the first 10 drugs they're negotiating before September 1st. So coming up here pretty quick. And then those prices would take effect starting in 2026 and kind of a rolling basis from there as they negotiate the prices of more drugs each year. But much like everything, it says, pending litigation, because there are a number of lawsuits, 8 or 9, I think, at this point, pending about whether CMS even has the right to do this negotiation, whether the way they have done it is correct, especially with the overturning of Chevron deference. I think this is another element that has a lot of meat on the bone and a lot to look at. So they can definitely look at these litigants and see if that's something that makes sense to stop CMS from this negotiation or not. Pardon me. Someone asked about copays being 25% for 2025. Is that the maximum it can be? Meaning the plan can still choose copays if they wish. I don't know for sure what you're looking at, Steve, but what you were probably looking at was the basic benefit design. Consider that kind of the bottom end threshold of if you want to offer a Part D plan, these are the minimum standards for what a Part D plan can offer and still be a valid Part D plan, kind of the bare standards to get the contract to offer a drug plan under Medicare. So yes, you'll still see many plans that have co-pays rather than co-insurance, especially on those lower tiered drugs in all likelihood. I think one potential change, we'll talk a little bit more about this in a second, but one potential change is you may start seeing the deductible apply to all drug tiers again, like it used to back in the day, rather than your tier 1 and tier 2 drugs being copay only right from the get-go. That won't be on all plans. It won't be from every carrier. Every carrier is going to tackle this a separate way, but we'll talk a little more about that in just a second. Last thing on the Inflation Reduction Act before we get into long-term long-term changes, the smoothing provision, the or M3P, Medicare Prescription Payment Program. This is something that's gotten a lot of attention. This is the program by which at the pharmacy counter, high-cost drug individuals can opt to pay $0 at the pharmacy counter, and they can be billed for those drug costs by the carrier on a monthly basis. So here's what I'm going to go over a few different things. Here's what this plan was designed to do. This prescription payment program, smoothing provision, whatever you want to call it, it was designed for grandma's got cancer. She's on an oral chemo medication that is $15,000 a month. In January, she's going to hit her troop. It's $2,000. And then she's not going to pay anything the rest of the year. But she still has to come up with $2,000 in January. And for some people, that's a lot of money. So what do? This gives grandma the option to go to the pharmacy counter and say, I would like to enroll in the prescription payment program. She pays $0 at the pharmacy counter, and her plan can now bill her $167.67 a month for the entire year. And she can spread that out over the course of the year. Any Medicare beneficiary with a Part D plan can opt into the prescription payment program. It will not and does not make sense for every beneficiary to do that. This is really for those high cost beneficiaries. There is a provision where pharmacy techs or pharmacists are required to notify people of this option if they have a single drug that is in excess of $600 per fill. So you will see if you kind of use that as a threshold of who it makes sense for, it starts to make a lot more sense. But as you can see, if someone's taking $2 lisinopril, this is not something that's going to make sense or save them money or do anything other than increase carrier administration costs. So definitely expect some confusion around this, confusion around who is and is not able to enroll in it. Again, technically everyone can enroll in it. It just doesn't make sense for everyone. Some of the big questions are, so what happens if they don't make a payment? Well, a couple things. One, if they miss 2 monthly payments in a row, the carrier can remove them from the prescription payment program. They would have to go back to paying at the pharmacy counter. They cannot be disenrolled from their drug plan as long as they continue paying their drug plan premiums. And if they send a check to the carrier is required to always apply that money to premiums first. So let's say they have an outstanding balance of $500 and they send in a $50 check for their monthly premium. The carrier is required to apply that check to the premium first, and then anything left over they can apply towards the outstanding balance. But they can't disenroll them from the payment plan. They can disenroll them from the smoothing provision or the payment program. The bad debt is another big question I've gotten a lot. If the individual has not paid up that debt by the end of the year, the carrier is allowed to pursue typically all typical methods of debt collection that are legal for medical debt. It would fall under kind of that medical information debt. So there's going to be some limitations to that, but carriers can pursue them through traditional debt pursuit, just like they would anything else. Good question by Dennis. It is only available for drugs on the formulary, not drugs that are not on the formulary. So still have to have the drug on the formulary for the smoothing provision for M3P. It does have to be covered by your plan to be eligible for that smoothing provision. All right. So what does this actually mean? This is maybe going to scare a couple people, and I certainly don't mean to do that, but we need to talk about it. At the end of the day, for Part D plans, specifically standalone Part D plans, higher premiums, probably more non-commissionable plans, tighter networks, a couple other potential things like more step therapy, more utilization management, potentially shrinking formularies. But reminder, there are minimum formulary standards. Don't think all of a sudden you're going to go out and buy a drug plan that doesn't cover insulin at all. It has to cover certain insulins and things like that. So don't freak out just yet. But higher premiums, biggest point of confusion. Ooh, the questions are rolling in now. Will they still be able to get extra help? Yes, the extra help program is not going away, has nothing to do with the Inflation Reduction Act. Extra help is still a totally valid and viable program. Definitely still available to folks that qualify for that, but is still available to folks. Roy's asking, what if the drug's not on the formulary but is approved by appeal? Well, if it's a formulary appeal and the plan chooses to cover it, then for that individual, it is a covered drug. So it would be eligible for the payment program. But let's talk higher premiums, because I've gotten a lot of questions about, well, what about the 6% cap on premiums? A little bit of a misnomer. CMS did set up a 6% cap on the base beneficiary premium that took effect actually this year. But what we need to realize is the base beneficiary premium does like three things, and none of them have anything to do with what a carrier can actually charge for a planned premium. It sets the baseline for Medicare reimbursement rates for drug plans for the basic Part D benefit. It is used as a portion of the calculation to calculate which plans are eligible for full LIS subsidies. And it is used to establish the late enrollment penalty for Part D. It's really the only three things that the base beneficiary premium does, and it's a very different number than the average premium or any of these other numbers that you may see thrown around over the next couple of weeks. We usually start seeing those at the end of July, give or take. So keep an eye out for those, but they don't always mean what you think they mean. So that's a lot of changes for Part D, and Part D is really stretched to the max. 11% to 29% exposure. That's a huge chunk of money. Premiums are going to have to go up. You've seen a lot of carriers even very publicly say double, maybe triple the premiums that they're charging this year. That means your average Part D premium could be as high as $70 a month. It's very likely that carriers may move to having a kind of a low, medium, high value plan. Carriers may move to only having two plan options that have traditionally had three, because they do still have to show a distinct difference between those plan options, a meaningful difference from an actuarial standpoint, to be able to offer them. So a lot of cost pressures on standalone Part D plans. It will absolutely also affect Medicare Advantage plans. Medicare Advantage plans have a lot more levers to pull. They have a lot more things that they can tweak and adjust to keep those premiums down, keep those premiums at $0. That's one of the biggest questions I've gotten. Are $0 Medicare Advantage plans going away? Unequivocally, no. Right now, today, 72% of Medicare beneficiaries that are on a Medicare Advantage plan are enrolled in a zero premium plan. That is arguably one of the most important numbers to a plan, and it is one of the least valuable numbers for them to change. There's something called TBC, total beneficiary cost. There are limits every year to how much an MA plan can change their total beneficiary cost. 2025, it's going to be $38. That is subject to adjustment based on price pressures and things like that from CMS. That's why carriers go through rebid every year. But what you'll see is a dollar is not always a dollar. A dollar of premium is always $1, because that's a dollar directly taken from the beneficiary. A dollar of copay for a primary care physician is $1 from the beneficiary. A dollar of certain other copays and coinsurances is $1. But something like dental or transportation benefits or healthy foods or any of these other ancillary benefits, on dental, $500 in dental benefit might be $4 in total beneficiary cost. So you've got a lot of levers that you can move to make up for the extra expenditures on Part D in a Medicare Advantage plan. But part of that means Medicare Advantage plans are going to be all over the board. Everyone's going to have to choose which levers to pull to help cover the cost of the changes to Part D. And you're going to see a lot less plan parity. If you're in a competitive market for Medicare Advantage, say anything over 45%, 50% MA penetration in that market, you've seen plan parity the past 2 or 3 years where a lot of the plans really look pretty similar. They'll have little differences in ancillary benefits or some new shiny thing, but at their core, you kind of get to pick which logo you like, and there's not a whole lot of difference in the core benefits. So that is probably going to change going forward. You're going to see a lot bigger differences between plans as they choose which things they think their beneficiaries are going to prioritize. Had a couple questions about formulary come in. One about, does the troop include non-formulary drugs or only those within the formulary? Nothing about that part has changed for 2025. Troop accumulation still only follows drugs that the plan is paying at least some part of, with the exception of those in the deductible. So they do have to be on formulary to count towards the troop. Let's see, will they have to pay $2,000 up front, or is it like anything else? They have to meet this amount as they are paying for their meds during the year. So again, that's troop accumulation, some changes to exactly what counts towards the troop, but no, they don't have to. It's not a $2,000 deductible. It's a $2,000 max out of pocket. The max out of pocket is $2,000. Their troop is $2,000. The maximum deductible is only $590. And again, every plan will still have a little bit different design on how they administrate that. Susan popped in and said, concerned about PDPs with high premium for those of us not taking meds or only a couple low-cost maintenance med. Don't want members dropping PDP and thinking the penalty will be less costly. Hopefully at least one option for low premiums for clients with no meds for years. Your thoughts? I think it's a wonderful thought, and I'm worried that that's all that it is. There are a lot of really fixed costs being thrown at drug plans this year. I'm not going to speak to any specific carrier and what I think they may or may not do on premiums this year, but I think low cost, yeah, there will be a low cost drug plan out there this year. It's probably not going to be the number you're used to, though. Low cost is going to mean something different. Will it make more sense for someone to drop a PDP and think that the penalty will be less? I would never advise someone to drop their PDP and assume that the penalty will be less, because of course we never know when someone can get that dreaded diagnosis, when they might go on to a high cost med. Really not a great option, but it is something you're going to have the conversation about this year for those folks that want that flexibility of a med sup, don't want to go to an MA. I think that's the other thing you need to be prepared for, is folks that want to look at MA versus Med Sup this year. Michael's asking about sneak peeks for 2025. Carriers will be rolling those out still, probably a little later than you're used to. Most of them have been pushed off to later this month or even August. And again, because of the rebid process with CMS, where the carriers will get notes back and they'll be able to rebid their plans, we're expecting some of the biggest changes that we've ever seen on rebid. If you look at some of the sneak peeks that certain carriers have already pushed out, it's pretty much, here's what markets we're going to be in, here's what benefits we expect to have, but no dollar amounts. Sneak peeks are not going to be worth what they used to be, and don't take them any further than you can throw them. Focus on what comes out 10-1. Let's hop into the final rule. Dnip changes. So first of all, let's get this out of the way. The final rule. There are a million final rules. The rulemaking process goes like this. Someone comes up with an idea. Something needs to change about this particular piece of policy. Agency issues a proposal, a proposed rule. Goes through comment period, goes through markup with OMB, goes through a series of policies and procedures, and then comes out as the final rule. In this case, what we commonly refer to as the final rule in the Medicare world is the policy and technical updates for Medicare Advantage and prescription drug plans, including PACE and all of those. 2025, there were a lot of things in that rule. Let's start with Dnip. If you're into the Dnip market, hey, we're going to do this as a favor to Steve. If you're in the Dnip market, click that little raise hand button so he can take a note real quick, because you need a phone call after this. This is a big deal. There are a bunch of huge changes to the Dnip market, changes to lookalike plans. A lot of this isn't going to impact as many people as you think it will. In Illinois in particular, it will be a big deal. Lowering that threshold for what constitutes a lookalike plan. A lookalike plan is a non-special needs plan, just a regular MA plan, where a large percentage of the enrollees are eligible for a dual SNP plan. Right now, today, the threshold is 80%. If a plan has more than 80% of their people that are enrolled in their non-SNP MA plan that are SNP eligible, they can lose their contract. This final rule lowers that amount over the next couple years down to 60%. So really trying to drive dual eligibles towards Dnip plans, and specifically through some changes to enrollment periods, driving them to integrated dual plans. So if you're in the dual market, you're probably familiar. You've got that quarterly election period. Obviously, if there's a change in their status, you can enroll them in a plan or disenroll them. And then you've got the LIS election as well. That quarterly election period for maintaining dual status is going away, no longer exists. The quarterly election for maintaining dual status is going away. It's being replaced. It's being replaced with a continuous monthly election period for standalone Part D only for people that are eligible for LIS. Again, standalone Part D only, which in many states are auto-assigned, and a new enrollment period that is the best way to think about it is kind of like a 5-star election, but it is an enrollment period that can be used at any time throughout the year to enroll in an integrated dual plan. So those are your FIDEs, HIDEs, and AIPs. FIDE, HIDE, AIP. Those plans are plans that either fully or heavily coordinate with an integrated medical managed care organization at the state level. So United Healthcare has an MCO contract with the state. United Healthcare also has a Dnip plan in the state, and those two plans coordinate care on a highly or fully integrated level. Those are your HIDEs and FIDEs. So those are your plans that now have this continuous 5-star type enrollment plan. Here's the downside. Right now, today, only about 20 states have those plans in them. Long term, the goal is to force more states into that model of using managed care organizations and allowing those carriers to create integrated dual plans and kind of getting those folks into a better managed care system. There's actually the Duals Act going through Congress right now that would require all states to operate on this basis. So keep an eye out for more of those changes. But the big change is AEP, OEP, SEP, just like anybody else, is the future of the Dnip market, unless you're in one of those states that does have integrated dual plans. And again, that's only about 20 states right now today. Benefits marketing. There's not a ton of marketing changes that came out this year in the final rule. There was the one-to-one consent that we talked about a little bit already. This was the biggest change to marketing, and it mostly affects carriers, since a lot of you are not creating benefit-specific marketing materials. Carriers have to change the way they market what I call qualified benefits, meaning special supplemental benefits for the chronically ill and value-based insurance design benefits. These are your pest controls. You're buying an air conditioner for somebody. Some of those not really health related, but kind of better for their health benefits. Those are offered under specific programs through CMS, and people actually have to qualify for those benefits. They're not available to everyone on the plan by default. Carriers are no longer allowed to market those benefits without clearly noting that there are qualifications to get those benefits and that they're not available to all enrollees. All carriers, starting next year, have to provide mid-year notices of which benefits an individual has used. So with those extras, the dental, vision, hearing, healthy food cards, utility assistance, whatever it is, middle of the year, they have to provide a notice. There's a couple different ways the carrier can do that, but they're going to have to provide a notice saying, here's your benefits. Here's a reminder. You've used this much dental, this much vision, this much transportation benefit. Here's what you have left. Here's a reminder of how to use these. So good things for beneficiaries. They're going to be able to see those benefits mid-year and hopefully use them. Some changes to mental and behavioral health. CMS added a couple new provider types at the beginning of this year that can now bill Medicare that weren't previously allowed to. They're also putting in some new systems for which types of providers can be used to meet network adequacy requirements for mental and behavioral health on an outpatient basis. Has to be someone who is seeing a certain number of patients per year for those services. Can't just be any particular, like an RN or an assistant physician. Those can satisfy this requirement as long as they have a track record of seeing people for those services. Definitely going to change how network adequacy is administered, and then change what carriers have to do to meet those guidelines. Before we get to the big one that I'm sure everyone wants to talk about, which is compensation, we're going to talk real briefly about home health care and skilled nursing. So right now today, if you're in original Medicare, you're in a skilled nursing facility, or even if you're in a hospital and you're going to be discharged, you get that notice of non-coverage and says, on this date, we're kicking you out. You have the ability to appeal that. You have the ability to fast track that appeal through the QIO, the Quality Improvement Organization. Those are regional contractors. There's a couple quick links that you can use to find what the regional contractor is in your area. But again, those are available 7 days a week, even on holidays. Hours may vary, but as long as someone puts a request for a fast track appeal in no later than noon the day that they're supposed to be discharged, they can get that fast track appeal processed, and they are allowed to stay in the facility while that appeal is being reviewed. The big change starting next year is that Medicare Advantage plans now have to also use the QIO for those appeals, the Quality Improvement Organization, instead of using their own internal claims and appeals team. This could have a huge impact. How many people, again, raise hands, pop something in the chat, whatever. How many people have had a complaint from a client that says, oh, my nursing home, my skilled nursing facility, my home health care agency said those Medicare Advantage plans are horrible. They just don't pay anything for skilled care. They don't want to cover nursing home stays, yada, yada, yada. Everyone has probably heard that story, probably had issues finding network coverage for some of those services. Sean, several. Yeah, absolutely. Happens all the time. This is going to change the game on how those benefits are administered. Now that they're going through the same process that original Medicare goes through for those appeals, it is possible, if not likely, that you're going to see more, or most likely longer, skilled nursing and home health care stays for folks on Advantage plans. It's going to take a couple years probably, but I would expect, if this goes the way we hope, that this is going to make it a lot easier to find in-network skilled nursing and home health care for your MA clients. This is a big win for clients if it goes the way we hope, as long as the QIOs hold up their end of the bargain and again, process those claims in a manner accordance with the rules. Last thing on the final rule, the big one, the 37 out of 1,300 pages, but the only thing anyone wants to talk about is compensation. Changes to the dollars coming into our pockets for the work that we do. And there were a couple big changes. You probably saw changes to fair market value, that extra $100 that's supposed to take the place of all the other money that we were getting, the marketing dollars, the co-op, the AHIP discounts, the state appointment fees, the marketing credits, the advice and support of your upline, the HRAs, all the other things, and they were supposed to be compensated for by $100 an app. And then of course, changes to who gets paid what and how that all works. And of course, there were some lawsuits. Last week, you may have seen in the news on July 3rd, the 5th District Court in Texas did issue a stay, an injunction against CMS, preventing them from implementing a couple of key provisions of the final rule, namely the ones regarding what counts as compensation and the fixed $100 amount for those additional services. That's a big deal. That means that that part of the rule is on ice. It's on hold. The CMS can't do anything about that until that lawsuit plays out. It doesn't mean that it won't eventually be enacted. It just means CMS will have to win that lawsuit at every level, all the way up to the Supreme Court, before anything changes. They could also choose to withdraw the rule, come back, and issue a new rule that tries to address some of the complaints in the original lawsuit. Lots of things that could happen between now and then and yonder, but the couple of those provisions are on ice for now. No major changes, little more status quo potentially compared to what we're used to, but a lot of these other changes totally intact, totally in place. Okay, what does this mean for you, for an agent? This is a lot. I realize that. Everyone take a quick breath. Crazy stuff. This year, we talked about that, 45 to 70% of people are going to need to change plans. 45% of the 33 million beneficiaries that are on a Medicare Advantage plan is 14 million people that will need to make a plan change on the low end. That is $5 billion in renewal commissions alone that are up for grabs this year. That doesn't count PDP. That doesn't count MedSup. That doesn't count new to Medicare. That is just people who are on a Medicare Advantage plan today that will probably need to change plans, and potentially agents. That's where your opportunity is next year. Avoid the noise, maintain your poise, keep your eye on the ball. This is such a huge opportunity. If you are new, someone popped in. I'm going to address this anonymous attendee real quick because I think this is a great point to make. I'm new to the insurance market. Do I need to obtain a Medicare supplement license? Been told different stories. Currently have both a life and health license. Talk to your team at New Horizons, their contracting department. There are a couple states that have weird licensure about med sups and different lines of authority and things like that. I don't know what state you're in, so I can't speak to that specifically, just on a basic level. But there are certain states that have weird lines of authority, and you have to have certain lines. Talk to the contracting team, an appointment team at New Horizons, and they'll get you straightened out on that for sure. But if you are new to the market, man, there has never been a better time to get into or to be growing a business in the Medicare space. Billions of dollars, billions with a B. I hope I said that really clearly. There's a lot of money on the table this year, and all you have to do is have systems in place to be able to capture that. Yes, you need to preserve your current book of business. We're going to talk about that in just a moment, but you really need to be able to grow also. And we're going to talk about a couple of ways to do that. Here's the 3 keys that I'm telling all of my agents, every agent I talk to. There are 3 key things that you need to focus on this AEP. You need to talk about time, tech, and team. And that's what's going to help you win this annual enrollment period. Time, you have got to prioritize. You've got to figure out where your time is best and most profitably spent. That's going to mean things like looking at your length of appointment. You cannot run hour-long PDP appointments this AEP. You're not going to make any money. Not only are you not going to make money, you're going to lose money running hour-long drug plan appointments this AEP. You've got to shorten that up. You've got to do it in groups. Do ANOC meetings. Do things where you can get all your carrier A clients, all your carrier B clients in a room together and present this to 25 people at once. Everyone feels heard. Everyone feels seen. Everyone feels taken care of. If they don't need to make a change, great. If they do, you can enroll them right there. Those need to be registered sales events. Again, New Horizons team can help hook you up with that system. This is going to be the way to make a profit this annual enrollment period. Do a little bit of refinement on your client intake process. How are you collecting data? How are you collecting drug lists, doctors, all that information you need from your clients to run an appointment? And are you doing it in a way that makes sense time-wise, that makes sense dumping it into your CRM? And where are you needed? And where you needed, specifically needed, not things you'd like to do, not things that are fun, not, the chit chat that you love to have with your clients, but where do you need to be profitable and effective this annual enrollment period? And where are places where if you have staff, your staff can step in? Where are the places where someone else in your office can take over a task, or you can outsource something? And then the last one on time, get all the carriers, get certified earlier. If there's that new carrier on the block or a carrier you're not super familiar with that you've been wondering, man, should I even contract with them? Definitely contract with them. We don't know who's going to win AEP this year. It's going to be a toss up. Get contracted with every carrier that's in your market or any market you expect to be in, because we're not sure who's going to come out the strongest this year. Let's talk about the tech side. The answer to time in a large part is tech. Some of it's priorities, some of it's internal systems, non-tech systems, but things like Medicare Center. You probably saw the sizzle video go out a couple days ago, the personal agent websites with the client sync feature. My gosh, what a tool. You can send a link to your clients. They can update their drug lists. It'll sync with their profile in Medicare Center and vice versa. It gives them access to that wallet where they can see a lot of their plan data. It's such a great tool for collecting that data right off the bat. You can start collecting that now. You can send people links to update their information right now. That way, by the time AEP rolls around, you've got it all, or you've got 80% of it. Nothing we're talking about today is a 100% solution. And I don't want you to look for a 100% solution. If you can find one thing that takes you 2 or 3 hours to set up and it works for 10% of your clients, I want you to think about exactly how much time that will save you over the course of AEP. What is 10% of your clients? Is it 100 people, 300 people? I don't know. It depends on how big your book of business is. But if you can find a solution, one little thing that addresses 10% of your clients and saves you that time, that's 10% of your time you just got back to find new clients. That's a huge, huge win for this AEP. Automate your outreach, systematize your follow-up, have things in place to make that appointment setting, make that drug collection, make all of that automated as much as possible, whether that's email campaigns through your CRM or email campaigns through your client manager, whatever it happens to be. Systematize that follow-up. What are you doing to reach out to clients? Make sure they got their drug card, make sure they got their follow-up letter from the carrier, whatever the case may be. Do you have someone checking on pending apps? Systematize all that. That way everyone's using the same system and nothing's getting lost. And use data to inform your decisions. If you don't have a CRM filled with all this information about your clients, you're going to be behind the 8 ball to figure out who to prioritize. And you have to prioritize your clients this year. Figure out who needs that one-on-one attention. Who are your high-value A-list clients that send you a lot of referrals, have a lot of products with you, are great advocates for you in the community, things like that. The people that need your personal touch. And then similarly, use data to figure out who are my more tech-savvy clients, folks that I know can handle an e-app on their own if I just send them a link through Medicare Center after we have a quick chat about what plan may work for them this year. And then the last one is team. Whether you are a team of one solo agent or whether you have an office with 20 employees, team is a critical aspect of it. And that means your team here at New Horizons too, the team that is going to help you get through this AEP. Set expectations, understand the pressure that everyone is under. Remember, 3 to 5x, 300 to 500% more appointments that we're expecting people to need to take this year to hit all the clients that need to make a change. Understand what kind of pressure that creates for you and the things you need to do to survive AEP. Let's talk numbers for half a second. If you take off Sundays, take off Thanksgiving, run, say, 45-minute appointments, 10 hours a day, take 30-minute lunch here and there, not every day, but here and there. That's a pretty rough AEP. That's one that I know a lot of you have done before. That's a lived experience that a lot of us have shared. But you're going to cap out at around 500 clients. If you've got more than 500 clients in your book of business, you literally can't see more than 500 or so working like that. Now, if you want to run 30-minute appointments, no lunch breaks, 12 hours a day, all 53 days of AEP, you could see 1,296 clients. And at the end of AEP, might have just enough time to get home and see the divorce notice taped to your front door, because it's not a great way to live. Really recommend finding some of these systems, some of this time and tech solutions to make sure the team, whether that's you, the team at the office, the team at New Horizons, the team back at home supporting you, make sure that everyone understands what's going on and that you have a plan in place. If you have over 500 clients, you need to be hiring someone. You need that help, whether that's a VA, whether that's someone in your office, whether that's another agent. Look at hiring now, setting those expectations, preparing people in your office already for what this new AEP looks like, and figure out a reward system. Everyone is motivated differently. Everyone is going to have different things that make them tick, make them go, make them drive. And you've got to figure out a way to reward that team for the incredible work that they're about to do and the incredible impact they're going to have on Medicare beneficiaries this year. With that, we're wrapped up. I know that was a crazy amount of information. I know that was a lot to go over, but please keep tossing questions in as much as you can. I'm going to stop sharing real quick so we can just stare at each other. And please, by all means, what can I do for you? I'm going to go back through a couple of these questions that popped in real quick. Any discussion of an SEP due to these drastic changes? Terry, no, there are no new SEPs just because of all this AEP craziness. I'm going to be honest, Terry, I read the SEP handbook that carriers put out every year, and there's like 97 of them. If you can't find a way to enroll someone, you're just not looking that close. And honestly, we need less SEPs, not more of them. Stability is what I think we need in the market. Most people need the opportunity to make the right decision one time. And all these SEPs, as we well know, unfortunately help people make the wrong decision sometimes. So I don't think in more SEPs is remotely the solution to this AEP. We just need to come up with those better systems and processes. Doug has asked, is there a CMS model compliant disclaimer information that we have to put on a lead form for one-to-one consent? Doug, no, not necessarily, because again, while it was a footnote in the final rule, the core of this one-to-one consent is the Federal Communications Commission, not CMS. This applies to all lead generation, whether you're selling cars and tires or whether you're selling home warranties or whether you're selling Medicare, annuities, whatever the case may be. This applies to all lead generation for all industries. So there is not necessarily model disclaimer information. Highly suggest you talk to some lead vendors, talk to an attorney voiced in TCPA specifically, because this is a part of the Telephone Consumer Protection Act, and definitely going to be a big deal going into next year. Now, implementation of that is pushed off until January of 2025. So it won't be as big an impact this AEP. But the big thing is start generating those compliant leads now, because any leads that were not generated compliantly under the new guidelines are dead starting in January, and you can no longer use them if they weren't generated compliantly under the new guidelines. So Tamia asked about, I hope I said that right, Tamia. She asked, they asked that I repeat the Medicaid rule there in Alabama. Does your state fit the integrated rule that I mentioned? Lost on what you said. Can you use some examples? I don't know off the top of my head about Alabama. I want to say you do have some integrated plans there. There is a huge file from CMS. It's called the SMAC, the SMAC file, that lists all the Dnip plans and whether or not they're integrated. The core of this, again, let's say Aetna has a managed care contract, a state Medicaid contract in Alabama. I don't know who does. This is examples. Aetna has a Medicaid contract to administer Medicaid in the state of Alabama. Example only. I don't know if they do or not. Aetna also has a Dnip plan in Alabama. If those two plans coordinate care on a fully integrated or highly integrated basis, they would meet the definition of this new continuous enrollment period. Someone who had the Aetna managed care organization assigned to them by the state Medicaid agency at any time in the year could enroll in the accompanying Aetna Dnip plan. If that still didn't answer your question, please pop another question in the chat, but I hope that makes it a little more clear. Natalie's asking about Medicare Center and whether or not that is a CRM. There are a lot of great CRM type features in Medicare Center. In fact, if you go through any of the trainings with Anna Patrick, with Integrity, or any of the other trainings available pre-recorded on Medicare Center, my gosh, we have rolled out some crazy new stuff this year. Including stuff like the personal agent websites, stuff like the client sync, things like Ask Integrity, the AI tool built into Medicare Center. If you're putting good notes in there and using it like a CRM, it's going to help you determine which people are likely to shop or switch their plan, which people you need to prioritize this AEP. And it's even going to be able to talk back to you and give you show notes from your last appointment. That way you kind of remember what went on, any specific concerns a client had. There are a lot of great things in this system that you can probably utilize. And thank you so much for the kind thoughts. Susan asked about the slide deck. Wonderful information and helpful. Thank you so much again. Welcome to the slide deck if they'd like to send it out afterwards. Is there a new disclaimer for 2025? No, Medicare disclaimer did not change at all. There were no changes to the Medicare disclaimer. Like I said, surprisingly few changes to marketing in general. There is not a new disclaimer. You do still have to continue to use the disclaimer that we've all grown to know and love. Thomas is asking, will the AHIP 2024 be okay for the AEP? No, you got to take AHIP every year. Or one thing I would suggest potentially, depending on what carriers you're working with, NABIP, the National Association of Benefits and Insurance Professionals, of which I am a member, does have their own Medicare Advantage certification. And the vast majority of major carriers take that. There's a full list on the website. There are a couple that don't, but the ones that don't usually offer some kind of AHIP alternative anyway. So definitely something to take a look at. Regardless, you are going to have to do 2025 certifications to be ready for AEP. And if that sounds like a lot to handle, reach out to the team at New Horizons for some help and assistance. Michael is asking about recommendations for a CRM with Medicare.gov API and a phone like RingCentral and Google. Man, Michael, you're looking for $1 billion solution to a $1,000 question. It seems like there's a lot easier ways to do that. Medicare Center is going to have all of the same data that you need. It does have a phone system built into it. It does have all of the same data that feeds into Medicare.gov. The carriers send the same data files to Medicare Center that go to Medicare.gov. So in terms of plan design and things like that, definitely a great solution. Maybe won't do everything you're looking for, but again, don't look for $1 billion solution to a $1,000 problem. Susan's saying, still trying to understand integrated carriers. Wouldn't that basically drive integrated SNP carriers into a monopoly scenario? Yes, absolutely it would, Susan. That's kind of the idea here. By people, I mean CMS, is really trying to consolidate that DSNP market down to a couple core carriers. Most states are going to have anywhere from 1 to 3 Medicare managed care organizations with their Medicaid at the state level. But yes, it's going to create a much narrower DSNP market because of that, especially if the Duals Act does go through Congress. That would require all states to move to that model. But definitely looking at this is a little bit longer term play. Short term impact is in those 20 states that currently have integrated plans. Longer term, jury's kind of still out. So don't worry about it too terribly much just yet. Steve is wanting to circle back to the ICL in Part D. Max deductible is $590. Max OOP is $2,000. In between is the ICL initial coverage limit, which is at 25% copay. Does that mean all RX have 25% copay, or it's up to no? So again, Steve, you're talking about the basic benefit design, the maximum allowable copays during the initial coverage limit for certain benefits. It does not mean that every drug is going to be 25% during the initial coverage limit. It means that the basic benefit requires that. So plan design is still drastically up to the carriers. They can offer an enriched or an enhanced benefit that is more than that basic requirement to any beneficiary. Got it. Good. When is CMS going to limit the amount of plans a carrier can offer in the MAPD market, just as Medigap was corralled? Kathleen, that's a fantastic question. Right now, nothing necessarily on the horizon in the short to midterm for that. No pending regulation or legislation to limit that, other than some of these tighter standards for what carriers can offer. Again, kind of looking at with the things going on in the Dnip market, that definitely will limit the number of plans being offered by the number of carriers. There's obviously a lot of chatter about that at the congressional level every year, especially this year during an election year. But in terms of, can I give you a date? Can I give you a number? Can I give you a time? Not even remotely. Right now, those are all still mostly ideas. All right. I know we are just a couple minutes over time. If there's anything else, please pop those into the chat. But I think we've answered all of them that we have in front of me, at least. What do you think, Steve?
I'm wondering when you're going to get better. No, I just, everybody can understand again. The synergies that integrity brings to the marketplace, Chalen, are second to none, and you're living proof of this, and we greatly appreciate the entire audience. We had well in excess of 250 people sign up for this today. I don't know what the final numbers are, but you can see that there's a lot of very interested people out there. This is one of many webinars we're going to be putting on between now and October 1st, just to try to help usher people into this AEP and kind of guide them through. And I think ultimately it's going to be a lot about time management. I'm telling brokers out there that if they've got something around 200 MA clients and under, they're going to be busier than they've been in the past, but it's going to be totally manageable. North of 200 on an individual basis, we could have to start putting some other systems in place and attack the problem from that perspective. But again, with people like Chalen, and we got others out there in the integrity family, we're going to get through this together. So feel free to reach back. Yep, feel free to reach back. And Chalen, once again, we'll be in touch.
Absolutely, Steve. Hey, let's address this last question real quick.
Sure.
Who should folks call there at New Horizons if they're looking to get set up, looking to review their carriers, looking for their first FMO or their last FMO? Who at New Horizons should they be calling?
That's me. So just
perfect.
Get into our get our phone number, ask for Steve, and they'll track me down.
Absolutely.
Have several conversations like this every day.
Good deal. All right. Well, thank you all so much. I don't see any last minute questions. So I know several folks asked about the slide deck, Steve. I know Jason's already got a copy of it. If you all want to send that out, you're more than welcome.
We're going to get it out. We're going to get it out to everybody. Let them it's very valuable information.
Perfect. Well, thank you all so much for having me.
Chalen from New Horizons, thank you very much, my friend. Thanks, everybody.